Okay, so our next speaker does not need an introduction. Next speaker is Professor Humaid Al-Shamsi. Professor Humaid is consultant oncology and the director of oncology services at Burjeel Medical City in Abu Dhabi. He is also the president of Emirates Oncology Society, and he is a social media sensation. Doctor, thank you. He will talk to us about neuroendocrine tumors today. Thank you. The floor is yours.
Clicker, remote control. Okay, assalamu alaikum wa rahmatullahi wa barakatuh. Today, first of all, thank you for the organizing committee for inviting me to talk about rare tumor in oncology. And the title, I made the title is rare, but actually it's not too rare. Neuroendocrine tumor, actually they're not as rare as you may think. Sometimes I see actually once or twice a week in my clinic a patient with neuroendocrine tumor, and this is my disclosure. And because the problem with diagnosing neuroendocrine tumor can be challenging, and this patient can be actually going on for a long time before being diagnosed with the neuroendocrine tumor, the term zebra has been associated with the neuroendocrine tumor, and hence the reference for the cancer for neuroendocrine tumor also carrying the zebra color. And sometimes can be very hard, even you have the rainbow colored zebras, which makes it even more or harder to diagnose. So I will highlight some of the burden of neuroendocrine tumor from our own study, and also the epidemiology of the neuroendocrine tumor, and also some update about the management. I'll keep it brief because I know most of you maybe will not be treating neuroendocrine tumor. So what's neuroendocrine tumor? These actually are diseases rises from epithelial endocrine cells distributed throughout the urodigestive tract and pancreas, and they do produce granules and melt salt uptakes, and frequently they express somatostatin receptor. The most commonly one are the GI tract in the appendix, large intestine, small intestine, pancreas as well, the lungs, but also we can see them in the thyroid, pituitary, and parathyroid as well. But certainly it can happen in different parts of the body, and that's why sometimes it's very difficult to diagnose or pinpoint for the origin of these diseases, and sometimes we call them unknown primary, and we still treat them with a similar way. And again, that's why also the color of the origin of these tumors. The incidence of the GI malignancies from C is actually showing here, but also we see the incidence of the neuroendocrine tumor are going up, even though the incidence of all cancers actually are maybe stabilizing or little maybe declining, but the neuroendocrine tumor are increasing. Is it because we are more aware of them, or is it because actually they are truly increasing? We don't know for sure, but certainly we are better in diagnosing neuroendocrine tumor now than we did many years ago. I cannot say much about histology and pathology because we have an expert here in the room, but the bottom line, the neuroendocrine tumor actually they are a group of diseases. They can be very mild, they can grow very slowly, but they can also be very aggressive, and there is some histological classification which has been revised 2019 by WHO, and this actually has a significant implication when it comes to the management of these patients, either by treatment, surgery, or even different chemotherapy sometimes if it's really high-grade tumor. One of the largest surveys for patients who's been diagnosed by neuroendocrine tumor, they've been asked a few questions. Some of these questions are like, how soon were you diagnosed? And most of them actually were diagnosed after being seen by at least 6 or 7 doctors. So patient goes, I have abdominal pain, well, you have constipation, take this. He comes next time, maybe it's IBS, take this medication. They come third time, well, maybe we need to do colonoscopy. Well, I don't have time, let's come back. So a patient, they keep coming back. And the problem is, if you don't think about this disease, and this actually I always tell the GPs or family physicians, if you don't think about neuroendocrine tumor as a possible cause, you will not be able to diagnose it. So you have always to keep this in mind. Not only about neuroendocrine tumor, but also about different cancers. The problem with cancer could be silent and could be also giving like non-specific symptoms. So many physicians, unfortunately, gastroenterologists, general surgeons, internal medicine, GPs, they may overlook these symptoms. And this study highlights, the delay in the diagnosis. I'm going to show you also the data from UAE. And 45% of the patients responding to this survey, they reported that they were diagnosed with different things, as I mentioned earlier, IBS, gastritis. Some of them also were labeled as psychiatric disorders, and also asthma and menopause. As I mentioned earlier, that patient, they can go to different subspecialties, and still you can see here the number of visits the patient has been going to the doctor before being diagnosed with the neuroendocrine tumor. You can see it could go for years actually before and this is actually what we see in clinic. Patient, when after they've been diagnosed, they tell me, like, doctor, we've been going to the doctor for a long time before being diagnosed. And again, 58% of this cohort, they started they were actually metastasized. They were stage 4, which is actually incurable or advanced disease, which is, again, it's a huge problem. And I'm talking now, I'm just remembering my younger patient who are actually, one of them was a doctor, and she was diagnosed with advanced disease, even though she went multiple times to see her physician or different physician, but still now she's stage 4. We cannot cure her because disease is too advanced in her liver. You cannot do surgery, you cannot do transplant. You have to do just systemic therapy, hormonal therapy. We did the study actually to look at the burden of the neuroendocrine tumor in UAE. We're publishing this actually very soon, inshallah. And what we did actually, this is the survey first. This is the survey. We just asked questions to all the oncologists in the country about their description first. What's your practice, medical oncologist, gastroenterologist, and then we have also asked them how many cases do you see per year, and most of them they see around 16 cases per year, which is something I think that's correct, and actually more are seeing less and less number. But the problem here, patient could go to any doctor before being diagnosed and then refer to the gastroenterologist, to the GI oncologist, and the problem also they keep shopping around, which is another problem with our patients. What's the most common type of neuroendocrine tumor in your practice? And as we expect, GI is the most common disease site, followed by lung. And what about the most common gastroenteropancreatic disease? And the most common one was the pancreas, followed by the stomach, followed by the small intestine. Maybe this is a little bit off, but I think the small intestine and pancreas will be the most common ones that we see in clinical practice. The number of my patients with the neuroendocrine are increasing over time, and actually the majority, 51%, agreed with the statement, and this is what we see. We're seeing more and more patients, and that's why I titled this Rare but Not Too Rare. In our upcoming book, actually, Cancer in the UAE, we dedicated a special chapter about neuroendocrine tumor in the UAE, and this is based on our study which we conducted during my time at Town Hospital. And what we did, actually, we did a retrospective study. We looked at 5 years data, and we found a good number of patients. And this is the first study in the Gulf region looking at the neuroendocrine tumor from UAE or the GCC. We identified 149 patients, and the majority were males, and they are different nationalities. UAE nationals were around 22%. And the majority, actually, they had no past medical history. They were healthy, and that's why when you are healthy, going to the doctor complaining of GI symptoms or other symptoms, you may not get the same assessment or concern. The peak of the disease was in the 20s and also in the 60s, late 50s and 60s. So there are two peaks. Abdominal pain was the most common symptoms the patient had at the time of the presentation. Primary site was GI, non-pancreas, like small bowels, followed by lung, followed by pancreas. And non-pancreatic GI, the most common was small intestine, followed by gastric, followed by appendix, and followed by rectal neuroendocrine tumor. And fortunately, 68% they were diagnosed with stage 4, which is advanced disease at the time of the presentation. Again, this is in keeping with what we see in the international numbers. As I showed you, 58% was in that cohort. The most common site, what we see is actually disease metastasis, which is the spread is in the liver, and this could be potentially resectable, not resectable, depending how long the tumor has been there and if you can remove it or not. And 46% of these patients, they had primary tumor resection, and 7% only had another resection. How do we treat patients with the neuroendocrine tumor? Well, it has to go to a multidisciplinary team where you have, oncologist, surgeon, radiation oncologist, pathologist, and radiologist come together to decide what's the best modality. And this is the way to go for any type of cancer. Any type of cancer should not be managed by one person. It should be a team effort. And again, it's a huge team actually to make these decisions. And genetics is also a very important, subspecialty. It has to be involved in some cases of the neuroendocrine tumor. Also radiology, cardiology, because sometimes you have involvement of the heart as well, and endocrine because you may have some secretion of hormones which affect the patient quality of life. Surgery is always the best option if you can do surgery, but sometimes I mentioned many patients, they come with advanced disease, so it's difficult to do these surgeries. And medical therapies, you have hormonal injections, also you have some other forms, which I'm gonna highlight to you. But again, surgery is the way to move forward if you can do the surgery. There are many things you can do for this patient. They have liver metastasis, you can burn it, you can cut it, or you can also do some radiation, depending on the size and the location, and also other factors, if the patient younger or older. I mean, it's a complex decision. There's no one size fits all. The somatostatin analogs are actually some forms of hormonal injection, which can be taken monthly, which reduces the secretion of the hormones from the tumor and also control the disease spread. They don't really get rid of the tumor, but at least they can control it for some time, which is very important, which can give the patient some advantage of survival. The lutetium was a form of radiation, internal radiation, where you inject the radiation into the areas of concern, and this has been also shown to improve patient outcome, and it is available here in the UAE. There are different questions regarding what should we do for this patient when they progress. There are some other forms of treatment, including everolimus, also Sutent. These are targeted therapy, and they can be used in patients who have advanced disease as well. I will skip this because this is really subspecialized, but the bottom line, there are different forms of treatment for this patient with advanced disease. I'm talking about the patient who has spread. If you have localized disease, you do surgery. How do you follow up this patient? There are different ways to follow this patient. You can do scans for them every 6 months or 1 year, again, depending on the type of the cancer, of the neuroendocrine tumor cancer, or also depending on the extent of the disease as well. What are we doing as Emerging Oncology Society? Actually, we're trying to establish, GCC net, group, so we can advance our understanding. Because again, until now, there are no data from the GCC, which is really disappointing. And we're trying to come up with a proposal for our colleagues from the region, so we can understand the burden of disease in the GCC. Also, we're trying to collaborate with different entities, including ENET and Neuroendocrine Tumor Research Foundation as well. What we did 2 years ago, in November 10th, I believe, 2021, we had the largest ribbon in the world, and this was entered into Guinness World Record. And again, it wasn't just about getting to Guinness World Record, but to increase the awareness about this rare disease. And we have to continue increasing the awareness, like what we are doing right now about neuroendocrine tumor. I would like to encourage everybody, you can use your phone. You can use your phone and you scan the QR code here. You can get this book. This is Cancer in the Arab World. This is our book, actually, which has been downloaded more than 280,000 times for free. And this covers different aspects of cancer in the region. And this is the first book covering this topic in the MENA region. And we're working now to do our second edition as well. And currently, actually, we are preparing our 2 other books, Cancer in the UAE, which is the most comprehensive book about cancer care in the UAE. And I would like to thank Dr. Ayman Hattab for his contribution. I know I bothered him a lot to get this chapter done, but thank you, Dr. Ayman, for your contribution. Also, we have the Healthcare in the UAE book, which is also hopefully coming in the next few months, inshallah. And with this, sorry, I dropped the clicker. I would like to thank you for your attention, and will be more than happy to take any questions.
Professor Humaid, and yes, the floor is open for questions. You can go to the mic.
Doctor, you said that you said that this disease is very rare. So, and when it's discovered, it's usually discovered at an advanced stage. So is there a criteria that a doctor should keep in mind to diagnose a patient when he presents to the clinic with, abdominal pain before jumping immediately to the most common diseases such as IBS and so on?
Again, as I mentioned, we need to increase the awareness about these diseases so they think about them. We're not asking doctors to think about neuroendocrine tumor as a first diagnosis of differential. And the problem is with the current practice of medicine, we always try to jump to conclusion without even doing proper assessment. Nobody takes history as we used to do. We're just doing that, test, CT scan, ultrasound. But the reality is you have to take a proper history. You have to think about differential diagnosis, and you have to keep this as one of the different diagnoses for abdominal discomfort, abdominal symptoms. As I mentioned, you will find it during your career, during your practice. If you're practicing GP, general surgery, or oncology, you will see patients with neuroendocrine tumor. So if we are not teaching or educating our frontline GPs or internal medicine or gastroenterologists to think about it, it will be missed for many years, and that's why we're seeing in the UAE almost 70% of patients presenting with stage 4. We do want to see stage 4. We want to see stage 1, stage 2, stage 3. We can manage stage 4. It's like, you have to live with this disease for a few years until you die.
Thanks, doctor, for the presentation. Actually, my question is just like a follow-up. So what indicators can the patient or the doctor be alerted to so that he diagnoses neuroendocrine tumors earlier?
Again, it could be silent for many, many years like many other cancers. You have to keep in mind if you have a patient, having abdominal discomfort, you've done some investigations, and investigations are basically not significant. You have to move forward with doing ultrasound. You have to do CT scans. You have to think of this disease. You have to keep it in mind. There is no single way to diagnose it. I cannot tell you if the patient has abdominal pain, he has neuroendocrine tumor. They could have abdominal discomfort. They have gases. They have burping. But definitely there are a huge spectrum of symptoms can happen from this disease. Also, there could be some flushing if the patient has, liver involvement. They could be having some wheezing. So it's a spectrum, but keep in mind, neuroendocrine tumor is there. It could be affecting patient without any clear, explanation. So have it as one of your differential diagnoses, and you'll be able to diagnose in the future, inshallah.
Yes, thank you. And do those patients really get, let's say, curative effects of these painkillers if they have abdominal pain and such tumors? Like, do they benefit from drugs? Or
you mean at the time of diagnosis, early stage or advanced stage?
Let's say early stage.
Well, patients with early stage, as I mentioned to you, the problem is they have no symptom, but as the disease starting to increase and you have liver involvement, they will have more abdominal pain. They may be taking some painkiller, but this is not a solution. You always have to find the underlying cause for the patient's symptoms. We can always give medication to mask the symptoms, but you, as a physician, as a good physician, you have to understand why the patient has these symptoms, including pain.
Sure. Thank you so much.
You're welcome.
Thank you. I think it really, like you said earlier, the lack of continuation of healthcare and the fact that patients do have the tendency to, doctor shop or hospital shop, they go from one hospital to the other. But I think recently there is a lot of effort to integrate the electronic health system. So hopefully if you look at the history and you see that the patient has the same problem multiple times and times again, then that can be a red flag. And thank you. It also emphasized that we need more of original research because this is definitely lacking. And with our young audience, hopefully more people would be inspired to do same as your great work.
وين هرب منا اليوم؟ ما شفناك. مشغولة.
Thank you, Professor Humaid. Thank you. We are honored. I think we have a break until 4:30. So we'll be back here at 4:30 with another session and very interesting speakers.